partner trial has just been one of the greatest reservoirs of information. And right now we're talking about prosthesis-patient mismatch in TAVR versus SAVR, and it is a partner trial cohort A analysis, and we're talking about a paper from JACC. I am with Philippe Pibarot, DVM, PhD, with the Canada Research, Chair in Valvular Heart Diseases, Canadian Institute of Health Research, and Quebec Heart and Lung Institute. This is a wonderful source of information. What in this particular paper are we looking at in terms of data from the partner trial?
So we analyzed the incidence and impact of prosthesis-patient mismatch, which is in fact residual aortic stenosis following the procedure, in the partner cohort 1A trial, so the high risk, both in the two randomized arms, TAVR and SAVR, to compare the incidence of mismatch in these two therapies. And also we analyze the impact in the non-randomized continued access, which, as you know, is a much larger sample. And what we found is that, so first we analyzed mismatch based on the first postoperative echo using the effective orifice area of the prosthesis index for body size. And we used the well-validated cut point of 0.85 centimeters square per meter square to define mismatch, and less than 0.65 is severe. And the main findings is that mismatch was less frequent and less severe in TAVR versus SAVR when we compared the randomized arm. And actually there was about 30% at severe mismatch in SAVR versus 20% in TAVR, and this was even lower, close to 14% in the non-randomized continued access.
Now, in terms of what does this tell us clinically? It gives us some encouragement, certainly.
Yeah, no, absolutely. It does provide some encouragement, because there are several studies, including meta-analysis, that have shown that mismatch, particularly severe mismatch, is an independent risk factor for poor outcomes, for increased mortality, less LV mass regression following surgical aortic valve replacement. So now what we found is that, well, with TAVR, we have less frequent and less severe mismatch, particularly in the patient with a small annulus, which is really the challenge when we have a surgical aortic valve replacement. Patient with a small aortic annulus, let's say less than 21 millimeter, generally have increased incidence of severe mismatch, and as a consequence of that, they have increased mortality. And interestingly, the TAVR performed very well in the small aortic annulus, and the difference between SAVR and TAVR becomes even more striking in this subgroup, where close to 35% had severe mismatch in the surgical group versus less than 20% in the other group. So I think this is an important message. And in a surgical group, the presence of severe mismatch was associated with 1.8-fold increase of mortality, even for adjusting the other risk factors. And we found about the same thing in the TAVR non-randomized continued access. There was an increase in mortality. So now we have an alternative, especially in those patients with a small aortic annulus, small thick ventricles, which are challenging patients with surgical therapy. We may use TAVR to reduce PPM and its consequences on outcome. Plus the fact that, interestingly, in this patient with a small aortic annulus, there is also less paravalvular regurgitation with TAVR, which is, as we know, one of the limitations or complications of TAVR. So it's a double benefit, if you will. You have less mismatch compared to SAVR, and also this is where you're going to have less paravalvular regurgitation. So in terms of hemodynamic outcome and thus clinical outcome, that's probably the optimal situation.
And what's the mechanics? What's explaining what you're seeing?
Well, yeah, it's interesting, because what we are seeing is that the effective orifice area, so the area of the prosthetic valve that is available for blood flow, is larger with TAVR. And there is a stent with TAVR, but it's very thin, and so it does not occupy much space in the LV outflow tract, whereas with surgical aortic valve replacement, even the best bioprosthetic valve, they have a stent that is a bit more bulky, because it needs to be sewed, by the surgeon. And so yeah, in terms of hemodynamics, it provides more physiological inflow and effective orifice area. And so as a consequence, the pressure overload, the gradient, the residual stenosis is lower with TAVR.
So what's the bottom line message out of this paper?
Well, I think the bottom line message is that TAVR may be a preferred approach in patients with severe AS, high risk, because this was based on high risk patients. We cannot necessarily extrapolate those results to other cohorts. especially those who have a small aortic annulus, may be a preferred approach to compared to SAVR to avoid or at least reduce the severity of mismatch and the consequences on LV mass regression and mortality. And this is what we're aiming for, I think, with aortic valve replacement, is to provide a more physiological, a more optimal replacement with no residual stenosis, and of course also no residual aortic regurgitation. And there are also other works ongoing on this aspect to kind of fix this limitation of transcatheter valve, and I think we have good solution now. And the valve that we have at the present time will prevent paravalve regurgitation are still maintaining good function in terms of forward hemodynamics and prevention of mismatch. So this is encouraging. I think we have now good devices that will provide optimal hemodynamic and clinical outcome.
So patient prosthesis mismatch is the issue, and we're talking about a paper in JACC. Please look that up, Pibarot et al. For CardioSource World News. I'm Executive Editor Rick McGuire.